I would like to start by thanking the committee for inviting me to speak today. And as Julie said, I'm not a nurse, but I have had the pleasure and honor of working with nurses and studying the profession of nursing for the last 15 years. So I want to start by telling you about Barbara. Barbara was a 25-year-old midwife from Southern Bohemia when I first met her in 2009. She is energetic and loves to try new things. As a teenager, she attended secondary school for nursing and graduated at age 19 with her nursing license. She continued her education to get a bachelor's degree in nursing and midwifery. Now she's an experienced nurse and midwife. In 2009, Barbara had been frustrated where she worked. Fed up, she said, with the conditions at her last job in the Czech Republic, the low pay and lack of respect from colleagues and patients. Barbara started to explore options for working abroad. An internet search quickly came back with a Czech firm that sends nurses to Saudi Arabia. She spent over a year working with them, improving her English, preparing herself for a new life in a foreign country, and was successful. Barbara worked in Al-Kharj, Saudi Arabia, as a labor and delivery nurse for over 4 years. And it was hard, she says, exhausting both physically and emotionally. Upon return to the Czech Republic, she returned to midwifery as well. Barbara says that it was an adjustment and that she knew that she would lower her professional skills upon return. That professionalism and professional identity of nurses is at root of my research. Professional identity became a focus of my work on migrant nurses through their discourses of migration activities. This project served as the foundation of my dissertation. I started collecting data for this project in the summer of 2006, with my field year spanning 2008 to 2009, and I conducted 2 months of follow-up interviews in the summers of 2013 and 15. During my year in the field, I was based in a healthcare recruitment firm, which I call Care for You. Again, all names are pseudonyms. And I worked for them part-time as their education coordinator. My data includes interviews and/or observation data from over 50 individuals, healthcare workers, recruiters, and educators. Approximately half of the nurses attended or started nursing school during communism, which enables cross-generational and comparison and cross-ideological comparison. I also have a few physiotherapists in the data pools, which allows me to compare nurses with non-nurse healthcare migrants regarding professions and opportunities. Care for You sends the majority of their clients to Saudi Arabia, but some participants in this study had experiences usually as care assistants in other parts of Europe. Although none of the nurses in my sample pool were oncology nurses specifically, there are other specialized nurses, ICU nurses, nurse midwives, and I note that Care for You now advertises specifically for oncology nurses and other specialized nurses. Firms like Care for You exist because there is a global demand for healthcare workers, as our previous presenter explained. The WHO reported in 2006 a chronic worldwide need for some 2.4 million more physicians, nurses, and midwives, and for almost 2 million more pharmacists and other paramedical workers, which these numbers have, of course, been exacerbated in the last 15 years. These shortages are mainly in the world's poorest countries, which also carry heavy disease burdens. Compounding existing shortages and inequitable distribution of the health workforce, the past few decades have witnessed expansion in the international migration of health workers, with patterns of migration becoming increasingly complex. This complexity requires facilitation through recruiters. Recent economic downturns have led to austerity measures and cuts in many health services, and major English-speaking countries rely on foreign-trained healthcare providers to meet their needs. More recently, these developed nations have become more and more reliant on international migrants to fill health worker positions across the skill spectrum, from home health aides and assistants to nurses, physicians, and medical specialists. With rising life expectancy and expanding elderly populations, this reliance is expected to continue in coming decades and in several health occupations even intensify. The phenomena of healthcare worker recruitment is so great that the WHO has a code of practice for the recruitment of international healthcare workers. And we have yet to determine the impact of the COVID-19 pandemic on these health labor statistics. The image I'm showing on the screen now might be a bit misleading. Despite the lower reliance on nurses as a share of the workforce, it is worth noting that nurses greatly outnumber physicians as a result. And as a result, the absolute number of foreign-born nurses in the 4 countries depicted have recruited, the absolute number of foreign-born nurses in the 4 countries have recruited, that they've recruited is larger than the number of doctors, physicians. Regarding nurses, these numbers from 2003 show main source and destination countries. And it's been difficult to find updated numbers, statistics for a number of reasons. Shortages go in cycles. Healthcare worker stats are often lumped together, so it's hard to tease out nurses specifically. And licensed individuals do not equal migrants. And so nurses who are licensed individuals may not be migrating as nurses. However, we see Saudi Arabia on the bottom row as an outlier for a number of reasons. They import almost 90% of their healthcare workers. Islamic law limits male-female contact between Muslims, leading to a reliance on foreign workers. They use English as a common language and healthcare system, which broadens their pool. And they provide accommodation and travel in addition to salary, which is a draw for nurses. So there is a market or a demand. But why do European nurses, like Czech in my study, and increasingly Polish and Slovakian nurses go to Saudi Arabia? Czech nurses go to Saudi Arabia because for many, it's the best option. Most of the nurses in my study were in their 20s when they went abroad, wanting to go before they have children. Some were older in their 40s with grown children. Regardless, they are women, primarily, who have opportunities that their parents did not, many of them discussing the option to travel. Many of the nurses who I talked to are frustrated with the Czech healthcare system. They believe that it is a good system, but it is underfunded, understaffed, and a system that does not respect them. Healthcare is just one arena in which identity maintenance is a complex transnational process. Primarily, the Czech healthcare system has not transitioned in ways that lead to new forms of professional identity. Although Czech healthcare has been economically decentralized and now offers fee-for-service treatments and a patient-as-customer approach, nursing as a profession has not progressed much past the assistant role or the physician's hand established during socialism. During the 1970s, when some Western systems shifted, giving nurses more responsibility and autonomy, systems in Eastern Europe did not. But because Saudi Arabia is built on the American model, nurses there have far more responsibility and autonomy. In this context, Czech nurses are traveling, working abroad as care assistants and nannies in Western European countries often. They're watching imported shows from the US and the UK and see that nursing can be different than what they experience at home. And we cannot forget the incentive of money, the economics. Czech nursing salaries hover just around the national average. So in my research, I've determined that there are 3 main motivators that drive nursing migration: economics, professional development, and personal development. I consider money an of course motivation. If a nurse did not list money or salary as a driving factor for her migration, I would ask and often receive the answer, of course money. We can see from the chart that nurses and midwives make near the national average, doing slightly better now than 10 years ago. However, as averages go, nurse midwives with specializations make about 10,000 Czech crowns more per year, and nurse midwives without specialization make slightly less than the average. The chart also indicates that in comparison, physicians today make more than double the national average and nurses' salaries, but this number does not demonstrate a gender difference where male physicians make around 15,000 Czech crowns more than female physicians. In comparison to private facilities, physicians can make over 100,000 Czech crowns, whereas nurses in private facilities average less than 30,000. Now, I just gave you a lot of numbers and discrepancies, but what I want to point out is that salaries in Saudi Arabia can average 4 to 5 times the average salary for nurses in the Czech Republic, and then in Saudi Arabia, on top of salary, they also include accommodation and travel to and from Saudi Arabia. So Saudi Arabia is also more attractive than Western Europe for a number of reasons. While Western Europe also has a need for nurses, it also has barriers. The expense of paying a recruiter to be placed in Saudi Arabia is equivalent to the cost of applying for a license in West European countries such as the UK, but that has no guarantee the license will be granted. In addition to licensing problems, nurses in Western Europe also face a high cost of living, language inabilities, and at times even discrimination still. So while money is the motivator, it is also a symbol of respect. Nurses in my interviews often cited their low salaries as demonstrative of how they are not valued within the healthcare system. Barbara compared her salary to that of a sales clerk. Magda indicates that the salary is not high enough to keep people who do not have a calling to the profession of nursing. Zlatka compares the different salaries she could earn in comparison to staying at home. I argue that many of the variables that motivate Czech nurses to migrate can be traced back to seeking respect in their professional environment and roles. This carries through to having a more holistic approach to care in which compassion and emotional work are important. In this respect, the UK, Irish, and Saudi healthcare systems match the approaches of care that they seek. This desire is both informed by and reflective of professional identity. Those nurses who are motivated by a need to improve their skills purely for a developmental reason and seek full employment in the profession seek professional development. Pavlina states, if I go somewhere, I can bring more experience and use it in this hospital, and maybe it can help, indicating she wants to learn new things to bring back home. She continues, I look at this problem like this, that I will have more experiences, but it depends on whether nurses and doctors will accept this, because sometimes it's very hard to show them new procedures and they don't want to accept it. And it can help, but they don't want a different way. This is an oft repeated statement where Pavlina indicates the resistance to changing how healthcare works in the Czech Republic, leaving nurses in this physician's hand position. Some nurses are motivated by the need to gain some sort of personal achievement, skills, or worth. Iva was 42 when we talked and had been working in the same unit and ward for over 20 years. She wanted to work abroad, not for the money, but because she had worked a long time, and for her, the work is the same. Working abroad will be new experiences. I am bored. She also hoped that her international experience would provide the foundation to move into a teaching position or into a different type of nursing upon her return home. Mirka shows us that we cannot necessarily tease these motivations apart, and that they all define the nurse's desire to go abroad when she lists the number of motivations: learning English, earning money, having new experiences, meeting new people, and seeing a new country. To conclude, while money can be a strong motivator for migrating, I argue that it's not that simple. Nurses in my study are seeking respect as professionals because they have a professional identity as nurses. When discussing professional identity, we are talking about one's perception of self in the context of the professional activities. But it is more than merely professional competence. Despite being positioned in a subordinate location in the biomedical hierarchy, most nurses strongly identify with their work, making it part of your professional identity in ways that workers in more mundane jobs often resist. Professional identity is founded in a nurse's personal history and developed through personal and professional experiences. It is discursive and iterative. In short, it is the feeling of being a nurse rather than working as a nurse. Much like research in other types of identity, my work rests on the theoretical notions that individuals perform their identities in context, relating to environmental norms and ideals, and internalize the values that drive their practice. Ultimately, nurses judge themselves on the basis of how well they perform their professional duties. They base their judgments on their own and others' expectations, their superiors, their peers, the public, and their patients. They adjust their expectations based on prior performance and adjust performance based on expectations. It is a constant process. And when nurses cannot find ways to meet their expectations in their home countries, they may seek opportunities in foreign countries where they can. Money is a motivating factor. They want to earn so they can buy a house, for example, but they also use salary and other motivating factors to find themselves as nurses. Thank you.
Wow, thank you so much, Heidi. This is brilliant. There's a question in the chat, but it's in Spanish. So Celia, are you able to tell us what the question is for Heidi?
So Cecilia Reyes is asking, in relation to nurses that migrate, how the population accepts for them to be looked after by someone that is foreign? And then they have another question that it's what kind of problems a part of the language they have when looking after this kind of patients.
Right. So if I'm understanding the question correctly, they're asking how the Saudi patients care about being treated by foreign nurses.
Yes. So
Okay.
it's about how the patients feel.
Right. From my understanding, 90% of the nurses are foreign. They're Malaysian, they're South African, they're Indian, Filipino, Czech, Romanian. They're coming from a lot of places. So it's very rare to have a Saudi nurse. So that's common. They do have translators. Some of the nurses do stay long enough to learn Arabic, but they've often talked about how when the translators are unavailable and they only work like 6 hours a day. So it's that they have to practice, medicine just without communicating. And some of them learn small bits. It depends on how long they're there. I do know some nurses who have worked there long enough to be fairly fluent in Arabic, but others have to make do with what they can and communicate it with body language, essentially.
Yeah. And is there any other problems that they face when moving to another country to work as nurses?
Right. The biggest problem, and I've written elsewhere, has been adjusting to a system where they have more protocols and policies in place. Not all Czech hospitals have the level of paperwork, as they say, I've often said, and working at a fast pace. So sometimes if they are tested on their English, they have to have a certain level of English because they use English in the Saudi hospitals. But sometimes their English is not strong enough or they can't operate as quickly. But the other big complaint has been the protocols, that kind of learning how to operate using the protocols that they've given, despite the fact that's why they want to go to learn how to work in these other professional environments.
Thank you so much.
Thank you.
Fantastic. Really appreciate that. That really goes to the heart of nursing. Protocols and guidelines, we know about those, and standard operating procedures. Thank you so much Heidi for sharing with us. I wish more medical anthropologists were interested in nursing. So it's great to have a different perspective from us looking at ourselves all the time. Really appreciate your presentation. I'm going